Okay, so just as a to start with, I'll introduce myself. I'm Carol Hope. I'm actually the CEO of Ipswich Hospice, which is a small 7-bed hospice out here in Ipswich, or Brisbane West, as some of us like to call it. So what I've been asked to talk to you about today is about palliative care, to give you a bit of an introduction into what palliative care is all about. I should tell you that I'm also a nurse. I've been working in palliative care for over 20 years. So whilst I always learn something new every day, hopefully if you have any questions at the end, I'll certainly hopefully be able to answer them. If not, I will probably know somebody who can. So what we've been asked to talk to you about today is to just give you a bit of an overview of palliative care and what we do and how it might, how we might get involved or be kind of connected in with people that are living with MND. So I should also say thank you very, very much to Stacey and to MND Queensland for letting us come and have a chat with you today. It's my pleasure to do that. So I've just admitted a couple of extra people in, and so welcome to you guys who've just joined, and I'm about to share my screen, so bear with me. Okay, so can you see that? Okay, there we go. So hopefully you guys can see my screen as well. Excellent. So we'll introduce Elizabeth a bit later on when she comes to do her part, which is all about advanced care planning. So first things to kick off with is really the question that everybody usually wants to know, which is what is palliative care and what does it do? So what I've got up there are a couple of definitions, which, to be honest, for those of us that work in this space, are a little bit dry, to say the least. So you've got the bottom one there is the World Health Organization, which is the one that we've been working with for a long time. And the top one is one that Palliative Care Australia, which is our peak body for palliative care in Australia, has come up with recently. But they are a little bit dry, so I really wanted to just pull out a few bits and pieces from each of those to try and give you the essence of what it is that palliative care does. And first and foremost, you can see that it's person and family centred. So people often ask us what makes us different from other specialties, and we'll talk a little bit about that a bit later on. But really that's the main difference really, is that we don't look after a disease. We're not particularly focused on the disease process, although that's part of it, but we look after a person and their family and their loved ones and whoever's important to them. So you can see in there as well that our goal is to optimise quality of life, and quality of life is different for different people, as you can imagine. So it's what you feel is best for you, for your quality of life and where you are on your journey, but also what is it that you want to get out of life, and what is it that you want to continue to do and what is important to you. So in palliative care, we work really hard to try and make sure that we optimise that as much as possible. And that last one there is really about, is exactly what it says, which is relief of suffering. So people, I think there's a lot of fear out there in the community that as people do approach end of life, people who are aging, people who are particularly frail, there's a perception of suffering towards the end, and our goal is really to reduce that and to relieve that as much as possible. And I can truly say and put my hand on my heart and say that in the space that I work in, and particularly at hospice, we do achieve that the vast majority of the time. Suffering is of course different to different people, and what that means for different people. But again, when we go back to the principle of palliative care being all about person and family centred, our job is to find out what is important to you and what is important to the family, and then we work with you as much as possible to try and make sure that all of your goals are met and that things are as comfortable as possible. So that's probably the best description I can give of what palliative care is. Just try and move through. Here we go. So, as I said to you before, palliative care means different things to different people. In fact, it's actually quite a new term. So many of us have heard of hospice care, and that's been around since about the 11th century. But palliative care is only a fairly recent term, and everybody always says to us, oh, you know, we don't like hearing about palliative care, so why don't we change the name? Well, the reason is that no matter what we call ourselves, we're always going to be associated with what we do. So, but palliative care has only really been around for about 30 years, and it was actually coined by a Canadian doctor who had visited one of the first hospices in the UK, St Christopher's. And he didn't want to go back and talk about hospice, he wanted to talk about something different. So he coined the phrase palliative care, and there you go, it's stuck. But it means lots of different things, and you will see these phrases that are up on your screen all around the place. You know, people talk in euphemisms a lot of the time, but essentially you'll hear about specialist care, you'll hear about supportive care. That might be something that your doctors and your care teams are talking to you about at the moment. Obviously there's hospice care, end-of-life care, care at the end of life, terminal care, and also the palliative approach. So what I guess my message is here is they all mean the same thing, and it's all about a goal, and the goal is to make somebody's end of life, whether that be years, months, weeks, days, hours, but to make that as comfortable as possible, and to enable those people to meet whatever goals that they have. So in terms of, for people that are living with motor neuron disease, I've picked out 3 of these kind of areas that I just wanted to kind of talk to you about, because these might be areas or words that you're hearing. The first one is about a palliative approach. And what that's generally about is really it's around your primary care focus. So that's your GP. And the approach of where we recognise that you have an illness, or potentially have an illness that is possibly life-limiting. So this is where we start to think about, okay, so what do we need to, regardless of what that length of time is or your trajectory is, what is it that we need to start thinking about now to make sure that things are all in place for later on? So this is where we start talking about advanced care planning, an early introduction to what palliative care services do, and start providing that little bit of support. Now, Elizabeth's going to talk to you a bit about advanced care planning later on, so I'm not going to go into that in detail. But then we move on to specialist interventions. Now, for people with motor neuron disease, you'll already be linked in with your treating teams, which most likely will be your neurologist and the nurses, the specialist nurses and allied health support that they actually provide. Now, their focus, their goal is still the same in terms of caring for you as an individual, but their main focus is really around treatment of your disease and making sure that your physical function is as good as it can be, and that your disease is under control as much as it can be as well. And they're starting to think about how they can, I guess, solve potential problems that might come up in the future. So that's what your specialist does. When it comes to specialist palliative care, what they do, they provide their health providers or health practitioners, they have a specialist level of knowledge. So whilst your neurologist has done extensive study in studying the brain and diseases of the neurological system, palliative care specialists also go through a significant amount of extra study, but they look at caring for somebody from a point of view of symptom management and assisting them to live the best life they can as they approach that end of life phase. As I said before, it's person and family focused, but most importantly, it doesn't just look after palliative care services or people that work in this space, don't just look after you physically and don't just focus on your disease process, but we talk to you about your psychosocial well-being, how you want to be socially, spiritual needs, cultural aspects of your care. So whilst, and one of the things that you may be hearing about or you've heard about in the past is when we talk about that pain is not always physical. Pain can often be, can come about because there's all sorts of other things that you're worried about or that are happening that you need other kinds of supports rather than just physical pain relief. And that's what our specialty does. It really kind of hones in on what is really important to you from all these different aspects of your life and how can we make things, I guess, better to make sure you have the best quality and the best end of life that we can. This one I just put in because I really wanted to give you an idea of all the supports that are around people. Now, this isn't specifically for people with motor neurone disease, but this is anybody that has a potentially life-limiting illness. So this can be somebody who may have a potential for cure even with, say, for example, requiring a transplant, but they're on a transplant list and they are potentially have that illness may be life-limiting. So all of these supports are around you. On the right-hand side there, as you look at the screen, you can see that those are the hospital-based supports, and you'll see there's lots of different areas within the hospital, including not just palliative care units, but also your emergency departments. They are able to access palliative care services as well. There's also outpatient clinics. So when you go and see your neurologist, we also run outpatient clinics for palliative care services as well. And sometimes we can get those to run side by side to prevent too many visits up to the hospital. Then you've got on your left-hand side, you've got all the things that are all where people might live and services that are available in the community. And actually, you know, it exists everywhere. We go anywhere. Palliative care can be provided absolutely anywhere. So the obvious one is in your own homes, or if that's somebody might live in an aged care facility. But we also look after people in the prisons that are suffering in this way as well. People living in group home accommodation, and a lot of that is provided with the general practitioner, so working in partnership with the palliative care services and your neurology team. Your peak body, the MND Queensland, this itself today, the fact that they're providing this information from myself and Elizabeth, they've invited us to come along today, really shows the level of support and thinking that the MND Society, that the MND Queensland has around supporting people at this phase of life. And of course, the other one is Palliative Care Queensland, which you can see on the screen is PCQ. And again, they have lots of different resources and what have you that can help, and information that you can access. And whether, you know, the other thing, it's not just about specific areas. There are other support systems there, like the ambulance service. We do a lot of work with the ambulance service around pre-hospital care. So if you call an ambulance, we've often had some work, we've done some work with them around, you know, understanding what your needs may be and any plans that might be in place. And the last one there is the primary health network, which helps support all of this system and puts it all together. That might be a bit kind of technical though, that one. I'm just trying to move us forward on this presentation. There we go. So one of the things that, questions that was asked was about settings of care. So where can you get it? Where can you actually have your palliative care, your whatever term you want to use? And in Queensland, basically, as I've said, it can be provided anywhere and by anybody, but there is a level of specialist palliative care when things really do need to be sorted out. Then that's the level that you need to go to. But we do have services that are in the home, and that's again whether you live in a group home, whether you're in aged care, or whether you're in your own private residence. There's people that can come to you, and people within the community that you can go to as well. In Queensland, we're lucky. We have 4 hospices in the state. I'm really blessed to be part of one of them. And here at Ipswich, we only have 7 beds, whereas the others have got 6 and 8, and one of them's actually only got 3 beds. But what we do, we're quite different to our hospital because we try and provide a level of care which is a step down. So not if you've got really, really acute needs, medical needs, then we're probably not the right place for you. But we do try to provide a home-like environment with medical, nursing and allied health support as well. So those are the 4 hospices. And then you've got the hospitals, which you'll all be familiar with. There's outpatients, there's the specialist wards. If you're on one of the acute wards, so if you happen to be unwell and you go into the hospital and you end up in one of the medical wards, for example, the palliative care team in the hospital can still come and see you whilst you're on a different ward. You don't have to be in the palliative care ward. So That's what they call consultancy, and all of the large hospitals in Brisbane offer that service as well. So if you find yourself in that kind of place, what I'd say is maybe ask your the nurses or your doctors at the time to see if you can talk to one of the palliative care team, and they are particularly good at getting services sorted out so that you can get home quicker as well. So there's a tip for you. Okay, so we've been asked, I get asked all the time about when do palliative care services need to be engaged? When do you need to start talking to them? And my response to that is always that for people with motor neurone disease, the earlier the better. And that's not because you want palliative care services to come in and take over what's happening. But what we want them to do is actually start that introduction phase. And you can see here what I've done with this particular graphic is you've got from diagnosis all the way through to beyond end of life, and whatever time that is, and like I said, it could be years, it could be months, weeks, whatever that time frame is, that this is how it generally looks. That in the beginning of diagnosis, you have more contact and more care, I guess, from your treating team, which is probably your neurology team. And palliative care can come in at the beginning, but not have much involvement. And over time, that involvement might increase. So this is what it might look like. In the beginning, we might want to talk to you about advanced care planning. Again, Elizabeth will go into that a bit more in a bit. But we'll introduce you to those services, and we'll find out more about you, find out what it is that you want, what your goals are, how you want to be cared for, what your social situation is and how you want it to continue to be. All of those kind of things, so that we can then make sure that we're well prepared for when the time comes. For that part in the middle, it's really about us, palliative care, potentially dropping in and out when we're needed. So you might not have much contact, but you might have quite a bit of contact depending on what your needs are. And if there's some symptom management, some physical symptom management that might be needed, and your neurology team are asking for a bit of help, that's when they come in and provide all that. And again, it's that psychosocial care that's really important. And then finally, at the end, you'll find that palliative care tends to have a little bit more of an active role when people approach that real end of life phase, those last few weeks or months of life. But it's really important to remember as well that we go beyond that. In palliative care, bereavement support is really, really important. And whilst I've got bereavement support right at the very end of this graphic, it really starts very much at the beginning, because there is a lot of grief and loss that people experience through their journey with a life-limiting illness. And we try and provide as much support around that as possible. And obviously, after somebody has died, we then continue to look after people's loved ones, their family and their friends, by offering that bereavement support for as long as they need it. So how do you actually get hold of palliative care services, and where are they, what do they look like? And the best real comment that I can give here is you really have to know about them locally, where you actually live, because it does depend on where you live. The services that are accessible to you in central Brisbane will be quite different to those that might be out at Mount Isa or Roma, for example. So it's really important that you ask around locally, around where you live and what those referral kind of patterns look like. Best person to talk to, without a doubt, is your GP. Your GP will be able to refer on, or provide you with information around what's available, and also get you linked in with different organisations and services as you need them. There's Palliassist, and I've just put the website up there. So Palliassist is actually run by the Cancer Council, but don't let that put you off. It's not just for people with cancer. It's actually for people that need to access palliative care, and they need to know where to go. So you can ring the number Monday to Friday. I think it's now 8 till 5, or you can go onto the website and they will provide you with a list of services that you can contact yourself if you want to. The other thing that you can do is talk to your neurology team, talk to your treating doctors, just like your GP, and ask for a referral to the local palliative care service if that's what you want to do. So, and they'll be able to, in actual fact, and I can talk certainly for the southeast corner. There's the palliative care services in the big hospitals, the Royal Brisbane, the Princess Alexandra Hospital, they have really good connections and good partnerships with the neurology teams in those hospitals. So often it just happens as routine, but sometimes if you feel that you're ready to talk to somebody in palliative care, then by all means ask your team to make a referral, because they'd be more than happy to do that. There we go. So I think this is my last slide, so you'll be glad for me to stop talking. But I just wanted to talk about a little bit about out-of-pocket expenses. I know this is something that worries people. It's conversations that I have every day here at hospice when new guests arrive here. And the reality is that the vast majority of palliative care services will be free. They will be covered under the public health service, unless you choose to go privately, and we'll talk about that in a bit. But then you may incur some expenses as a result, and not specifically for palliative care, but generally in terms of being looked after in various locations. So if you're at home, you'll know that your medications, you'll be paying for your medications, and sometimes you'll be able to get those through the hospital, but sometimes you may have to get them through your GP. Now, hopefully you will be part of the safety net system, so after a certain time that you won't need to be paying for any of those medications, but that's just always something that we mention. The other thing is pickup, equipment delivery and pickup. So usually the equipment itself we can provide for as long as you need it free of charge, but there might be a drop-off delivery because we might have to organise for a courier to get that to you. Continence aids is the other thing. We try to keep those costs down as much as possible, but they're just things that we may need to ask for support with. And the other thing is your allied health support. Now, a lot of that will be part of your treatment plan, so that's not, you won't have to pay for that. But if there's anything unusual outside of that, you may have to pay for an allied health assessment, for example. But that is, I have to say, that's quite unusual. Hospice, very much the same. Obviously, we have all the equipment here, so we don't charge you for equipment, but certainly medications, continence aids, and allied health support. And what I would say is that GPs particularly are incredibly mindful of the costs that medications can incur. So we don't swap and change around all the time for no reason at all. There has to be really good reason as to why we would swap and change medications, because we understand that that does have a cost implication for people. Now, I mentioned earlier about possibly going into the private hospitals, and there are palliative care services that exist in places like the Wesley Hospital. St Vincent's Brisbane is a private hospital as well, and you might incur some out-of-pocket expenses just like you would if you went in for surgery. And again, that's around those medical gap payments and also some of the medications that they might have. So, but in all honesty, I can truly say that in palliative care, we do try to keep those costs down as much as possible. And we do everything we can. I'm not going to say that we break the rules, because that would be wrong, but we certainly bend the rules a little bit occasionally, just to make sure that we keep everything, all the costs down, and that if we can get around a problem, we absolutely will. So I think that's the end of my bit. Yeah. So I'm going to stop sharing my screen, and thank you very much for listening to me, and pass you on to Elizabeth.
Sorry everyone, I've just taken myself off mute. And I just need to, that's it. Can you all see that now? Yeah, great, okay. I will just nip through the slides to where I'm starting. So I'm Elizabeth Davis. I am also a nurse. I worked at the hospice, Ipswich Hospice, where Carol is, last year, and have done a variety of roles in palliative care over the years, including end-of-life lead at an ambulance service in the UK. So today I'm going to be talking to you a little bit about advanced care planning and also around a thing called dignity therapy and biography services. So advanced care planning, which Carol has mentioned, is the idea is behind it is, as it says here, thinking about and making choices to guide your future healthcare. So it's really a way of you thinking about what's important to you, what matters to you, and what services and support that you would like when you're getting to the end of your life. So as it says, it is voluntary, it gives you the opportunity to discuss your beliefs and values, and peace of mind that you have some say and some control over what happens to you when you're getting to a point when you can't actually, you don't actually have that ability to communicate for yourself. So it's can be written sometime in advance, and it can be changed as often as you like during the process, normally done with your GP and with family members' input if you so choose, to really get to a point of understanding and making clear what your wishes are around your priorities and what's important to you when you're getting towards the end of your life. So as it says, why plan ahead? To have your wishes known, to help guide the treatment and care you receive, to let your loved ones know what you would want if they need to make difficult decisions on your behalf. And I think one of the main important features of advanced care planning is that it gives your loved ones the understanding of what you want. So they are, if they need to make decisions, they know what your wishes are, and they can make sure that those decisions are made in the full understanding of what you want, and allow your choices about healthcare to be considered before a crisis occurs. It's very common that a crisis occurs and there's nothing in place for decisions to be made about what the next step is and what people would like. And so advanced care planning can really help to stop that occurring. So that things are smoother and easier and less difficult in these crisis situations for both the individual and for their family and their healthcare providers. Okay. So one of the big factors within advanced care planning is around the concept of capacity. I just might go to the next slide and come back to this one. So capacity, as I say, is very important in advanced care planning, and that capacity refers to the brain's ability to make a decision. It's very fluid and can change over time, and it's based on an individual decision. It's not about overall capacity, but how this individual can make a decision at the time the decision needs to be made. So advanced care planning requires an understanding of the capacity of the individual to input to the advanced care plan at the time it is completed. And there are different types of forms and processes involved in which process and which form you use based on your capacity. So if I go back to this previous slide, so we have an advanced care plan in Queensland called the Statement of Choices, and I'll go through the next slide, which gives you the way to the process for completing an advanced care plan and what you do with that advanced care plan. But there is a Queensland Health validated process and form that is used, Statement of Choices and advanced care plan, and there are two types of that. There's Form A is for people with capacity, and Form B is when the person doesn't have capacity and somebody else is helping to inform the advanced care plan on their behalf. But you do have, if you're going into the world of advanced care planning, you'll see there's lots of these different terms which can all be quite confusing. The website that I'll show you in a minute does have some explanations of all of these, so you can look at those for yourself at your choice. So you have Statement of Choices of Advanced Care Planning, which is a document which asks you about what's important to you, what would you like, those sorts of questions, open-ended questions, trying to understand what it is that's important to you and what you would like when you're getting to the point where you aren't able to communicate anymore. But there are other forms available, and all of them have uses in different contexts. So an Advanced Health Directive is a more formal legal document that is used, and you can appoint an attorney to be an advocate on your behalf with an advanced health directive. So the advanced care planning is not a formal legal document. You don't need input from a legal team or a lawyer into that. That will be signed by your GP and the individual or their decision maker. But an advanced health directive is a much more formal and legal document. And people can have choices about whether they wish to go down the advanced health directive route or they wish to develop an advanced care plan. Then what we do is we move through the substitute decision maker sort of list there. So if people do not have capacity, you can identify an appointed guardian with the Queensland Civil and Administrative Tribunal can be appointed, and that person can be a family member or a friend, somebody who can help to make decisions on someone's behalf. You can have a guardian can be somebody who's just making decisions around one particular issue, or they can take a broader variety of decisions. But that is somebody it's identified that that person lacks capacity to make decisions on their own behalf, and somebody will be appointed in a formal way by the QCAT to help that person as around decisions that can be made around their health going forward. Then you've got the enduring power of attorney, and there are two types of that. One is for finance and one is for health. The EPOA for health is very specific to health issues for the individual, and that is somebody that frequently that'll be a family member who will be appointed frequently at a time when you've got capacity, and you will agree that that's the person that you want to have to assist you in having the ability to make decisions on your behalf going forward. And we see that quite frequently in the elderly, where they'll appoint an EPOA of one of the family members to assist them when they get to a point when they're no longer able to make decisions on their behalf. So that's something you do in advance of a sort of a loss of capacity, and that person, that is not specific to advanced care planning or end of life. That an EPOA can be for any sort of decisions, as can a QCAT guardian. They can be around things like where people should live, if they should go into aged care, all those sorts of things. A statutory health attorney is somebody, if there's nobody who's suitable to be a QCAT appointed guardian, or there isn't an EPOA in place, then the government will come in and identify somebody to help make decisions on your behalf. That's a statutory health attorney. And then the public guardian is a very formal process of somebody from the Queensland government who becomes the guardian of an individual, particularly if there's disagreement around treatment or care. And again, it's things like people leaving hospital, going into aged care, those sorts of things. That's when you appoint the public guardian. So sort of going from informal down, from ACP down to more formal, but the ability to make sure that the wishes and the best interests of an individual are maintained, irrespective of their capacity or ability to communicate or make decisions. We've gone through that one. So advanced care planning in Queensland. So the steps of advanced care planning, and this is all from this website, which is the Metro South Health has an Office of Advanced Care Planning. And they have on that website a variety of forms and information around how to access advanced care plans. You can download the forms, all sorts of really useful and interesting information about how advanced care planning works in Queensland. So the steps that they identify, and mostly you would do your advanced care plan with your GP. You should talk to your GP, talk about your health conditions, and with your family, your values, your beliefs and preferences for your future healthcare, and to document these wishes in an advanced care planning document, such as the statement of choices, but also you can access the existing power of attorney and advanced health directives from here. And if you need a substitute decision maker, that will be identified in this form. I think one of the main benefits of the advanced care planning, the Office of Advanced Care Planning in Queensland, is it makes it very easy to share the copies of the ACP. So one of the big issues is you can complete an advanced care plan, but how do you make sure it's in the hands of the people who need it when you need it? And that's been one of the major problems, is that you have a form. It doesn't. Somebody calls an ambulance if you're not well. It doesn't go to hospital with you. Your GP doesn't have copies, etc. So this is really an attempt to make sure that once you've got an advanced care plan, it is shared with all of the people who are likely to need to see this form, so that your wishes can be met. So the Office of the Advanced Care Planning has a process of, you will see if you go onto the website, where you can upload the form and it will be shared on the Queensland Health Viewer. So this is an IT system within Queensland Health that is used across all Queensland Health facilities, and also is accessible by your GP and can be put up onto My Health Record, which is the Commonwealth Government's primary health record for each individual. So using this process and going through this website means that unless you're probably in Queensland, the only people who wouldn't have access to this are private hospitals, but any public hospital and your GP should be able to have access to the form, so that when you need your advanced care plan to be enacted, somebody has access to it and can follow your wishes. Okay. So the next thing I wanted to talk about is something called Dignity Therapy or Biography Service. So Dignity Therapy and Biography Service are basically very similar things, and they are a way for people with life-limiting conditions to reflect on their life, find meaning and leave messages for loved ones in a written narrative document. So basically, this is a process of recording people's life stories and leaving the life story of an individual in a document, and it can be electronic, it can be paper document for your family, for your loved ones, which is your story. And they've become both ways of doing it, and I'll go in a minute into the differences between the two, becoming really common and popular, particularly in life-limiting conditions and in palliative care services, as a very powerful way to record what was important to you in your life and to leave a legacy for your family and loved ones. So Dignity Therapy was started in Canada, and about 10 or 15 years ago, widely accepted now into clinical practice, and it's quite a structured process and frequently done by trained therapists in forms that are quite structured as to the questions that you might ask and the process you might follow to sort of tease out the story and the life story and what's important to people. Though Barwon Health, and my next slide has a video of Dignity Therapy at Barwon Health in New South Wales, which is a public health service in New South Wales, uses trained volunteers for this process. The Biography Service are more likely to be volunteer-based, and they're more of a free-flowing process around. They don't have structured forms or anything. It's really just a process of going through asking people around their lives, and once people are trained, spending time with them to do this. Both processes take quite some time to do and really involve developing a relationship with the person who would come normally to your home and just listen to you, talk to you, ask you questions and pull out the story of your life. And from that, they're trained to pull together a document which they will share with you, which will have your life story, and then you can share that with whoever you like. Also in Queensland, Griffith University runs a course in biography service as part of their arts program, and that's the link to the bottom there, which they call they have students doing this as part of, as one of their subjects, a second year subject at Griffith University. Okay, so the video here is actually an example from Barwon Health of a man with motor neurone disease and the process of developing a life story for him. Using Dignity Therapy. I did suggest to Stacey, every time I watch this video, it's very moving and a little bit upsetting. I always cry, but then I cry at anything. Just to give you that advice before, but I think it's quite moving and really good illustration of what this can do, what this can mean for people. And I'll play the video. No, okay. Maybe we'll just send the link through to everyone. Stacey, it looks like it's a bit difficult to share, but I think it is a really good example of how important this has been to Bruno in his journey, and the benefits of doing something like that. In the slide as well, down the bottom is a link to an actual life story of somebody. So it's an example of what a life story looks like. So for people can have a look at that as well when they'd like to. So Stacey and I've had a little bit of a chat about this. Obviously, in order to implement dignity therapy and biography service, motor neurone disease association would have to make a decision about how it might want to implement something like this. But I think that it's, I feel very passionately that it's a very powerful tool, and something that people can really focus on and really give them, a way to tell their story. And that's always very important. Everyone has an interesting life story. And I think that's one of the things when we we went to the Corona Hospice in North Brisbane and had a conversation with them about the program. They've had this running for quite a few years, and they train volunteers in biography service. And just that everyone thinks, I don't actually have a very interesting life. But in fact, everybody has an interesting life. They have stories to tell. They have, and the stories that your family would want to hear, things that you don't talk about, things that people don't know, and they could be brought out during the process of development of a biography or dignity therapy. So I think it's where I've seen it. It's been a very powerful tool, and very good sometimes also at bringing the family together, doing it with your family, and for people to talk stories, families, and having worked in hospice where Carol is director now. People getting together and talking about family stories and shared history can be a really powerful tool, and particularly at this time. So that's me. Thank you. Thank you, Steve.
Excellent. Thank you so much, both Carol and Elizabeth. I really appreciate your time going into preparing that and speaking with us all today. So I'll definitely send out Bruno's story to all of you that are in attendance today, and when we post this recording online, we'll put a link to that next to it as well, so people can get a feel for what it is. I'd be curious, or I'd be very keen to hear from you all about whether that is something you would like us to look into offering from M&D Queensland. So if you can let me know your thoughts, that would be much appreciated. But whilst we've still got Elizabeth and Carol, does anyone have any questions that you wanted to ask either of them? No?
There's a question. When you do an advanced health directive or a statement of choices, you can make it as nuanced as you like. But if there is an emergency, how do you make sure your doctor knows what you want, as opposed to, oh, here's signed a do not resuscitate form?
And I think that's the point of being able to share the document so that your wishes are known. Right.
That's the question. The document is shared, but who has time to read the document when you're taken to ED in respiratory failure from pneumonia, for example?
Yeah, I mean, you can do your best, I think, on having it available. If it's in the IT system and it pings up when you come into the emergency department that you've got an advanced care plan, then it is possible for them to see that. Nothing works perfectly. There's nothing perfect for these because there's no time to make, as you say, these life and death decisions, particularly around resuscitation, are made very quickly. So it's just an attempt to be as available and for people as much as you can in as many circumstances as you can, so you have the best chance of your wishes being met.
I think also it's worth adding to that. That's also why it's really important that your loved ones know what your wishes are as well, because then they're in a position to voice your wishes and point to an advanced health directive before interventions do take place. All right, thanks for that, Andrew. Any other questions? No? All right, well, nice to see all your faces again. Thanks again, Elizabeth and Carol. Really appreciate your time on that. And yeah, look forward to working with you both into the future. All right.
You're welcome.
Day, everyone.
Bye, everyone.